Hello, and welcome. I'm Dr. Molly Quinn. I'm a reproductive endocrinologist at UCLA.
And I'm Dr. Jesse Mills, director of the men's clinic at UCLA and a reproductive male specialist.
We're going to be speaking today about fertility considerations for the transgender population. As a reminder, you can ask questions on Twitter with the hashtag UCLAMDChat or comment on Facebook during this webinar. By way of outline, we will introduce the topic, and then Dr. Mills will talk about reproductive options for trans females, and I will speak on reproductive options for trans males. Many transgender individuals are of reproductive age at the time of transition, and they may wish to have children in the future, or may not know. Our international and national organizations agree that transgender patients should have access to the same options as any patient who is facing treatment with the potential to impact reproductive capacity. We know that exogenous hormones and gonadectomy, or removal of the gonads, can have an impact on fertility. As a result, we offer fertility preservation, which may include sperm, egg, also known as oocyte, or embryo cryopreservation. At this time, ovarian tissue and prepubertal testicular cryopreservation are really experimental, which means that fertility preservation for children prior to puberty is not a real possibility. I'm going to turn the microphone over to Dr. Mills to talk about fertility considerations for transgender women.
Great, thanks, Molly. And it really isn't that hard. I want to simplify this because reproductive endocrinology is not that difficult if we break it down into hormones, anatomy, and surgery, and that's what we're going to do. And certainly from my perspective, we're going to look at this from a hormonal standpoint first. And so if you look at the way that a 46XY person develops and goes down the typical phenotypic male pathway and decides to transition, there's a lot of things that we can do to preserve fertility in those women, or even before they go on hormone therapy, do something to preserve it through cryopreservation, as Dr. Quinn was talking about. So with that in mind, let's do a little bit of reproductive endocrinology from a 46XY perspective. And so what we look at is the first hormone is FSH, or follicle stimulating hormone. It's actually first mentioned in females, which is why it's called follicle stimulating hormone, but it's actually exactly the same hormone. It's made by the pituitary gland, a little gland sitting right here behind our noses, and that signals in 46XY people, it signals the testis to make sperm. So we have to have good levels of FSH in order to generate sperm production. That's kind of why it makes it tricky in young girls that are transgender, in that they are not making sperm at the point where they might consider hormone modulation. So that tissue being underdeveloped and not yet sensitive to FSH won't make sperm, which is what Dr. Quinn was talking about at the beginning. That's a special challenge. But for someone that's already gone through puberty, it actually isn't that difficult. So what happens? FSH is secreted in the pituitary gland. It signals the testis to make sperm. Once sperm is made, it can either be ejaculated or harvested surgically. So let's break that down a little bit more. If you put someone on a drug that will modulate or suppress FSH, their sperm production goes away. And it turns out that all of the hormone therapies to help transition a 46XY to a transgender 46XY, or a female, are going to interfere with FSH. So we need to figure out how to get the testosterone level back up in order to stimulate sperm production again. So how do we do that? Estrogen therapy suppresses FSH, and high levels of estrogen is what in the testicle make it even more difficult to make sperm production. And so we have to reverse that process. The key to doing that is reversing FSH levels. We got to bring it back up. And what that does is two things. One is it will bring up sperm production, which is what we want. But what we don't want, unfortunately, is it will also bring up testosterone production, and that testosterone will lead to some of the untoward side effects that transgender women are trying to avoid. So the masculinization is real. So we have to come up with a scenario where we limit that exposure as much as we can, so that these women don't have to go through too much stress as they are trying to reestablish sperm production. So what's in my tool chest as a male reproductive specialist? What can I do to get sperm from these women? Essentially, there's three ways to do it. There is a drug that's been on the market for decades called clomiphene citrate. And again, this is a drug we use in reproductive endocrinology all the time from both a female and a male perspective. So as you imagine, it's really no different in a transgender population. All we're doing is kickstarting that FSH to go up to a higher level. What that does then is it stimulates both sperm and testosterone production. And after a period of either days to weeks to months to even, unfortunately, years, depending on how long that woman was exposed to estrogen, will be when we start to see sperm production start up again. Is there any way we can turbocharge that or make that process a little bit faster? And the answer is HCG. So HCG is, again, something that everybody makes. In women, it's what we call maternal testosterone. And so when a 46XY fetus is developing, HCG is what stimulates male differentiation. And what we know is then if you are on hormone suppression and your estradiol levels go up and your pituitary hormones and testosterone go down, HCG restarts it just like it does in utero. So it's a very effective way to kickstart production of both testosterone and sperm as well in people that are on any kind of steroid regimen. Interestingly enough, I use this all the time in my practice on men that are anabolic steroid users because it's exactly the same process. They're suppressing FSH and LH, and when they do that, they are causing testosterone and sperm production to go down. So as their muscles are getting bigger, their sperm production goes down. So in a transgender population, as they're becoming more feminine, their sperm production goes down. But we reverse it pretty much exactly the same way. So there's a lot of conservation in biology, thankfully, makes my job easier and ultimately more successful. And then lastly, we do have to worry a little bit about hyperestrogenification, which of course is the point of transgender therapy from a hormonal perspective. But unfortunately, again, those high levels of estradiol will suppress testosterone production and sperm production in the testicle itself, not only in the pituitary gland. So again, we have all kinds of ways to treat this and reverse that process. The real key to doing this is doing it as minimally intrusively as possible. And so, at least in my practice, and I'm sure it's probably the same for you, Dr. Quinn, most of the time we're already seeing people that are transitioning, and so we have to figure out how to reel that transition back in just enough time to be able to either preserve oocyte preservation or, in my case, sperm preservation. But obviously you'll educate me as well as the audience on that side of things. Okay, so say we win. Say I'm able to get sperm back, and now what do we do with this? So this actually depends on my patient. If she is comfortable obtaining a semen sample, usually through masturbation, then it's pretty easy. If we find sperm in it, we freeze it. And the cryopreservation process has been very well vetted over the years, and it's something that we do on a daily basis. So this is not hard. Taking that tissue, we freeze it, it can freeze forever. So that's easy if she is comfortable performing a semen sample. But what if she's not? That's easy. There's still a lot of things we can do. If she's comfortable with the procedure when she's awake, then the next step is to do penile vibratory stimulation. And again, I'm borrowing from everything else I know as a male reproductive specialist. So for men that are unable to ejaculate, usually my spinal cord injured men, we use a penile vibrator, and that actually can stimulate an ejaculation. So in a transgender female, we can do the same thing if she's uncomfortable providing a masturbatory sample. Just a very well-directed penile vibratory stimulation can produce an ejaculation independent of sexual stimulation. So it takes a little bit of that pressure off her. And then lastly, if that doesn't work or if she's uncomfortable with that, then surgical sperm extraction, again, is something, as you know, we work together all the time with our reproductive couples. We do, and I do as a male reproductive specialist. All I have to do is bring sperm, and then Dr. Quinn does the rest on her side to establish that pregnancy. And it's exactly the same thing here. The only difference is usually what we're doing is taking that sperm and freezing it for later use. But it's exactly the same surgery. Usually it's, for me, just doing a little bit of local anesthesia, numbing up the testicle, and then putting in a tiny little needle and aspirating out a bunch of sperm. That's the easiest, less cringy way to describe what I do. And so we can either do that under local anesthesia or under a general, especially if I think I'm going to have trouble finding sperm, or if those hormones don't recover as much as we want. So again, once we get the sperm, cryopreservation is a pretty tried and true process for the sperm. And so by using a sperm bank, once that sample is either extracted by me or provided by the woman, that can be frozen in a liquid nitrogen essentially forever. So it can be used at all times. And the neat thing about that is then if we have that transition window where if I can do this for a couple of months and I'm able to at least see any sperm back in the ejaculate, we run right to the sperm bank and are able to freeze it, and then she can start the retransitioning process or continue and go on with anything from complete feminization and bottom surgery as well. So that's the beauty and the advantage of cryopreservation, and it is something we offer at UCLA as well. So with that, I'm going to turn it over and let Dr. Quinn walk us through the rest of the presentation. Thanks,
Great.
Molly.
Thank you, Dr. Mills. All right, so we're going to talk about fertility considerations for transgender men. So testosterone generally suppresses ovarian function. And I say generally because there certainly have been reports of individuals who have unintended conceptions or pregnancies while on testosterone. While this suppression is generally reversible, the ovarian response may be less than expected or may take some time in a similar fashion as Dr. Mills was discussing. So this may take up to 6 months following testosterone cessation. When the ovaries do undergo this process of waking up or reversal of that suppression, insemination is possible if a trans male would like to conceive and carry a pregnancy. For others, they haven't yet considered this possibility, or they would like to keep the possibility of conceiving in the future open, or perhaps they have the idea of having a partner or a gestational carrier carry a pregnancy for them. For these individuals, we offer fertility preservation, which may mean egg, oocyte, or embryo cryopreservation. And the distinction here is that in order to create an embryo, we fertilize eggs with sperm, and that can be donor sperm or partner sperm. Thawed eggs or embryos can subsequently be used. They can establish a pregnancy by transfer into a patient's own uterus, into a female partner, or a gestational carrier. So there is some flexibility here. In general, it has been recommended in the past that an interval of 3 months should be waited following the discontinuation of testosterone prior to treatment for fertility preservation. The idea here is that the ovaries are going to be suppressed, but really the truth is that there are individual differences, and some of it may have to do with the age of the patient, and some may have to do with the duration of time they've been on testosterone. But in general, the usual approach has been stop testosterone, wait 3 months, and then undergo a fertility preservation treatment cycle. What does that look like? 8 to 14 days of injections of medications. These are gonadotropins. So Dr. Mills was talking about FSH that comes from the pituitary or the brain, and it stimulates the gonads, ovaries, or testes to make hormones. So these are synthetic versions of that same hormone that is present in the body, the FSH, and these injections are given 2 to 3 times a day over the course of 8 to 14 days. Those injections are right underneath the skin, so we call them subcutaneous injections. During this period of time, there's frequent office visits, 4 to 6 over the course of that 2-week period, and ultrasounds are being done and blood work is being done to monitor treatment response. Following this interval of stimulation of ovaries, there is an egg retrieval procedure. That is done under sedation. So patient is not feeling anything, unaware of the process. It is a transvaginal procedure. So a needle goes through the vagina and into the ovaries, and the eggs are removed. All mature eggs can be cryopreserved for subsequent use. And really that's indefinite, so very similar to sperm. How long can you leave them cryopreserved in an indefinite period of time? There are some special considerations for this population, for trans males that wishing to consider fertility or preserve fertility. We have to think about the impact of discontinuation of hormone therapy, so very similar to what Dr. Mills was discussing. Additionally, there may be heightened gender dysphoria during this process, not only because of the discontinuation of testosterone, but also because of the hormone treatment itself. estrogen levels tend to be quite high during a fertility preservation treatment cycle. Similarly, estrogen levels are high in pregnancy, so that has to be considered ahead of time. We have to think about the ultrasounding that we're doing. I talked about monitoring that's happening, coming in for frequent visits. In the general fertility population, these ultrasounds are done transvaginally. It's the best way to see the ovaries and monitor treatment response. But I found that for my trans male population, I can often have a different strategy. So I can do transrectal monitoring, which may be preferred, or abdominal monitoring with ultrasound if that's preferred by a patient. And then I think I alluded to this at the beginning, but we have to remember the flexibility that this affords. So there's the possibility for the future use of donor gametes and or surrogacy. It's the same thing as a gestational carrier. So important to keep in the back of our mind if we're considering egg versus embryo cryopreservation. If you freeze an egg, that does give you some flexibility for use of a donor sperm in the future, for use of partner sperm in the future, whereas an embryo is an already fertilized egg. That flexibility may not be present for the future. So I think we have some questions from those who are listening. Okay. Many patients ask me to describe how invasive the process of fertility preservation is for a trans male. And I did talk a little bit about the ultrasounding that's done. One important consideration here is the route of the ultrasound, whether or not it's vaginal versus rectal or abdominal. And in general, I would say that every patient is different, but many of the trans males that I've worked with have preferred to undergo transrectal or abdominal ultrasounding, which is usually very sufficient for monitoring treatment response. And then that final egg retrieval procedure that's done under sedation is in fact done under sedation, so that discomfort is really minimized. Anything to add with respect to discomfort involved in the process?
Right, Molly. I think this, from my perspective, this is very gratifying because I find that our transgender population are very motivated, and they get that they're going to have to do something in order to achieve those fertility goals. And so I don't find that to be a barrier, the invasiveness, other than what we discussed about whether or not she's able to provide a sample organically or whether we have to end up doing something surgical. But again, it's a lot less than you would imagine, and I think the motivation level is there that I've never seen that as a barrier when we discuss motivation. It certainly just becomes a further discussion on what their goals are. And I will say that if you just back up a little bit and realize that as reproductive specialists, that we're both surgeons and reproductive endocrinologists, we have a really busy practice, which means that there are all kinds of people that come to us with barriers to fertility that we have to repair or fix, either surgically or with hormones. So we don't see this as any different situation. This is, we have the skill set and the tools to work together to make this a reality. And so I think that that's the take-home message is, yes, there may be some degree of invasiveness, but it wouldn't be any different than, say, somebody that has a history of cancer that we deal with, where we end up having to do something surgical to either preserve eggs or in my case to either preserve sperm or find sperm in somebody after chemotherapy. So the answer is there is invasiveness probably, but it's really no different than a lot of other people that are going through fertility struggles.
Great. So another question is a common question, which is the best time to do this in an individual's life? And that's a really difficult question to answer. But in general, actually, the best time to be doing this from the trans male perspective would be prior to initiation of testosterone therapy. And that is because really it is difficult for a lot of individuals to come off of that testosterone in order to undergo fertility treatment. And so if we do this prior, I think that minimizes or lessens some of the gender dysphoria that one might undergo. And the next issue is really, timelines with respect to pubertal maturation. I think I alluded at the beginning to the fact that we're really in the experimental phase of being able to harvest gametes from prepubertal children. So that really isn't at this point an option for us, although there are some centers undergoing experimental studies. So my general thought would be that probably prior to testosterone therapy, if possible, understanding that not everyone is thinking about fertility at the time that they're considering undergoing a transition. I did read a study recently that suggested, it's a Dutch study, up to 60% of trans males had a desire or wish to build a family that was biologically related to themselves. So it is something that at some point in the life may be an interest, even if it is not initially. And so we do often counsel patients prior to initiation of gender affirming hormonal therapy about this option.
And I would echo exactly what Dr. Quinn said, but really, when is timing ever perfect in anything? So right, if we could isolate as a woman is at least post-pubertal, but before she goes on any sort of estrogen therapy that would suppress sperm production, that would be great. I think the key is that if you are plugged into a great gender health program that is comprehensive, such as we have at UCLA, then you don't have to make any decisions. And this will be part of your counseling about how we do this. And then when Dr. Quinn and her colleagues and I get involved to make sure we steward couples through this process or individuals through the process, because timing is almost never perfect in medicine, and we can figure it out.
Another question is a common and important question for all patients in any area of medicine, which is, what will my insurance cover? And I am finding more and more that this can be a covered benefit. So I have had patients for whom this has been covered as a part of their treatment. So I think that that is promising. When we see patients for an initial consultation, we also have them meet with our financial planners, and they will interface with their insurance company and figure out exactly what will be covered and what may be an out-of-pocket expense.
Exactly. Most of what I do, first of all, on the sperm side, we're kind of a rounding error in the world of reproductive endocrinology, because all the technology is on the cryopreservation of eggs and also egg retrievals. And so everything that I do is relatively cost effective, but of course that's only half the picture. So in terms of getting initial office visits covered and getting the hormone modulation covered, we're usually pretty good at that. The actual sperm freezing, that becomes a little tougher because there are costs associated with that usually insurance doesn't cover. But it's really relatively cost effective, and I would hesitate to quote any numbers because it depends on a lot of factors. But that part is something we can certainly work with.
And then finally, a lot of patients are worried about this recommendation to stop treatment for a certain duration prior to undergoing fertility preservation. So we can both address that. From my perspective, this 3-month kind of blanket does not apply to everyone. And so there is an opportunity to have visits earlier on following discontinuation of testosterone to really see, are the ovaries kind of waking up, so to speak? Could we start sooner, and to try to minimize the impact and discomfort of patients?
Great. And in my perspective, there are not a lot of great studies that show how long it takes. If I extrapolate to other populations that have the same hormone suppression and recover sperm, there are some studies that I was a part of about 15 years ago now almost that show it's about a 3 to 7 month window for sperm production to come back, and it really depends on the patient's exposure to hormones prior to when they want to start the process of sperm production, what we call spermatogenesis again. So 3 to 7 months is reasonable. I've had some people, even specifically to transgender, that just by stopping the hormone therapy they recover a little bit faster. But she was did not have as much estrogen exposure. So again, individual results may vary, but somewhere in that 3 to 7 month is what I usually quote.
Okay. All right, I think that's all the questions from the audience.
Oh, this is great. Well, we really appreciate the opportunity. I hope that you learned something, and again, if you have any questions, please feel free to reach out to us and reach out to the UCLA Gender Health Program as a whole. Thanks very much for tuning into this webinar. Take care.
Thank you.